Management of afferent limb obstruction using EUS guided creation of a jejunojejunostomy and placement of a lumen apposing metal stent. Listed are authors' disclosures. Afferent loop obstruction is a complication of gastrojejunostomy reconstructive surgeries with a low incidence ranging from 0.2% to 20%. The cause of afferent loop obstruction can be benign or malignant. The afferent limb serves as the pancreaticobiliary limb, and its obstruction leads to symptoms resembling small bowel obstruction. In advanced cases, jaundice and cholangitis can develop. Definitive therapy of afferent loop obstruction typically involves surgical correction. However, in cases of advanced malignancy and recurrent metastatic lesions, endoscopic therapies could become the main therapy of choice. Endoscopic creation of enteroenterostomy using lumen apposing metal stents serves as a therapeutic option in bypassing obstruction in such scenarios. A 49-year-old Jamaican woman presented to our tertiary care center for management of afferent limb obstruction. She has a history of diverting loop gastrojejunostomy in the setting of an obstructing mesenteric desmoid tumor that was diagnosed 15 years ago. She was recently diagnosed with metastatic adenocarcinoma with peritoneal carcinomatosis that had poor response to multiple different regimens of chemotherapy. A CT scan of the abdomen and pelvis with IV contrast was performed and showed a central mesenteric soft tissue mass that was previously diagnosed and biopsied about 1 year ago with evidence of metastatic adenocarcinoma. But now the mass has intervally increased in size, encasing the superior mesenteric artery branches, occluding the superior mesenteric vein, and causing an obstruction with significant dilation of the duodenum, proximal jejunum, and the common bile duct. Treatment options were discussed in a multidisciplinary fashion. The patient was not a surgical candidate given the vascular encasement of the mass. The oncology team and the patient elected for palliative treatment measures to improve the quality of life. Endoscopic therapy was deemed to be an appropriate choice in this case, which would entail EUS-guided creation of an enteroenterostomy using a lumen apposing metal stent. This is a diagram that illustrates the patient's gastrojejunostomy. On initial examination, the pylorus was found to be obstructed. The endoscope was advanced, and the gastrojejunal anastomosis was found to be congested, yet patent, and was eventually traversed. The afferent limb was obstructed and hard to identify, however, the efferent limb was identified and examined. Once an appropriate position in the proximal end of the efferent limb was identified, the common wall between the jejunum and the obstructed jejunum was interrogated using color Doppler imaging to identify interimposed vessels. The jejunum was then punctured under endosonographic guidance with a 19-gauge needle. Bilious fluid was aspirated, confirming puncture into the obstructed afferent limb. A long stiff wire was inserted through the needle and into the afferent limb to secure access. A 15 mm diameter by 10 mm length lumen apposing metal stent was then advanced and placed with the phalanges in the close proximation to the walls of the bowel. Copious amounts of bile were seen extruding into the stomach. This is an illustration of the stent in place. The patient noted cessation of emesis and was able to advance her nutrition to soft diet. A CT scan abdomen and pelvis was performed to assess response to the lumen apposing metal stent placement. The CT scan abdomen and pelvis showed interval placement of the stent along with an interval improvement of duodenal and proximal jejunal dilation as well as interval decrease in the intrahepatic and extrahepatic bile duct dilation. The patient was eventually discharged home, and she elected not to pursue further chemotherapy and opted for comfort measures. The patient expired 1 month later. In conclusion, afferent loop obstruction can present with a spectrum of gastrointestinal symptoms including nausea, abdominal pain, and bilious vomiting, and can lead to jaundice or cholangitis in severe cases. Endoscopic management of malignant afferent bowel obstruction adds a great value in cases where surgical correction is not a viable option. Endoscopic creation of enteroenterostomy using lumen apposing metal stent was successful in bypassing malignant small bowel obstruction of the afferent limb in a patient with a history of gastrojejunostomy.